Hey everybody, this is Dr. Brady, the founder of Integrative Diagnosis. What I'm going to share with you today is some original research that we have done. We're always claiming to get great results, as lots of providers do, but we finally are recording the data and publishing the data. So what I'm going to share with you tonight are the results of some changes in a straight leg raise that we obtained at an instructor's meeting. So let's walk through what we did and what we found so you can make an informed decision about whether ID is something you think is useful for you, your practice, and your patients. So what we're going to start with here is one of our core principles, our first principles. We've got 7 of them. One of them is to measure everything. If you don't measure it, you can't manage it, you can't track it. So we've got to measure things. The immediate sub-question to measure everything is simply, is the measurement accurate and is it reproducible? There's no sense in measuring something if you can't reliably and accurately repeat the measurement, if the measurement isn't an indicator of the thing you're trying to determine. So what we did, we took one of our standard lumbar and hip tests, the straight leg raise. This is one of the 5 functional examination procedures we do for the hips and lumbar spine. We had 3 different providers all measure the same patient. And the provider doing the measurement was blinded, as well as the patient was blinded. Now it's a passive examination, but still, the provider that did the measurement did not share that information with the other providers or the patient. So it's a blinded examination. You can see here on the left side, well, before we get into the results, in ID, we measure straight leg raise differently. We developed a more precise measurement. One of the problems with straight leg raise is if your knee goes into hyperextension or remains in a bit of flexion, it throws off the actual measurement for the hip range with the knee extended. So we establish a neutral with your knee, and this can vary by as much as 10 degrees. So we're very precise in our methods, and we're very precise in the exact steps involved in a straight leg raise. If you're doing straight leg raise in practice, good for you. If you're not measuring it, or if you're simply considering it a disc test, we've got a lot of good information for you here. So here we go. So on the left side, the first provider measured 79, the next provider 76, and the third provider 74. As a weighted average, this is 76 degrees plus or minus 3 degrees. That's really good. That's solid. You're hard pressed to measure anything in the human body with this degree of specificity. Keep in mind the margin of error, we're using an inclinometer, and we're taking a 0 point in the middle of the tibia with the knee extended but the hip still in neutral, and then we're reading that measurement again. So there's 2 points at which we're measuring off of the inclinometer, and just reading it alone, you can be a degree or 2 off. So within 3 degrees is plus or minus 3 degrees here is really, really solid results. And what you'll see on the right side is we get 65, 72, and 65. The weighted average here is 67 plus or minus 5 degrees. Still really solid math, because the end point of straight leg raise is when you get to moderate tension or symptom. So to have a pretty variable end point with this level of specificity is really, really solid. So again, the providers were blinded and so was the patient. These numbers were really reliable. And here's the most important thing about this. If we were deciding whether to treat this patient's left or right side on these numbers alone, the providers were in 100% agreement on which side was involved. You can see all of these numbers are lower than these numbers. So as a next step principle, the measurement is certainly accurate and reproducible enough with 3 different providers with the same patient, not only got similar numbers, though it also decide that this is the restricted side. Not all things in manual medicine are that clean. So before we get more into what happened with this straight leg raise is we have to make sure if our first principle is to measure everything, and we've determined now that it's accurate and reliable, we also have to just sidestep here and say, is it important? In school, chiropractors learn to do all kinds of things. You take x-rays and you measure small degrees of changes on those x-rays. You look at hip heights, leg length deficiencies. You can think what you want about those things, but the question is the measurement important? Is that thing you're measuring important? So if we think about a straight leg raise, what we're doing is measuring your passive ability of your hip to flex with the knee extended. And the number one reason why that would be limited is sciatic nerve adhesion in the posterior hip. So the sciatic nerve between the external rotator muscles. The second most common reason is the sciatic nerve at the hamstrings and the posterior thigh. The third most common reason is adhesion in the hamstrings themselves. And fourthly, way down in single digits, is a space-occupying lesion of a lumbar disc that is also compressing a nerve root. This is your list. And you might be thinking, wait a minute, in school I only learned number 4, and number 3, sort of, but it was hamstring tightness, not adhesion. Well, we don't have time to get into all of the details, but I do want to show you this slide at the bottom. The surgical research is clearly demonstrating adhesion is the number one cause of sciatic nerve entrapment. You see here, this is labeled table 3 from a research article. These surgeons go in, and on the right, you can see the pictures. This top left slide here, this shows FT fibrous tissue. And all of this looks like it's basically covered in a big spider web. These are fibrous scar bands or fibrous tissue or neurovascular scar bands. We call it adhesion. It's sticking these structures together. Contrast this slide in the top left with this slide down here on the bottom right. This is post. See how clearly you can see the sciatic nerve here and the surrounding muscles all are pristine. And here, they're just absolutely covered in adhesion. So these surgeons have found, and these are surgical cases, so they're the worst of the worst. 13 out of 24 people had fibrous and fibrovascular bands. 8 of the 24 had muscle issues where the muscle is directly compressing the nerve. And then there were some other way less frequent ganglions and other nerve disorders, space-occupying lesions. So this is not a manual therapy construct. This is not a technique construct. There is tons and tons of research demonstrating sciatic nerve entrapment via adhesion. And if you want to look more into that, Google deep gluteal nerve or deep gluteal space, and you will find a lot of great videos. Coincidentally, we developed these procedures prior to ever seeing these surgical videos. So when you have separate professions finding the same thing independently, scientifically, that's a really big deal. That lends a ton of weight to those findings. So now that we've determined our measurement is important and it's reproducible and reliable, what we did next was palpate. So if the number one reason is adhesion between the sciatic nerve and the external rotators, we palpated for adhesion in this space. The surgeons call this the deep gluteal space. We call this sciatic nerve at external rotators. Keep in mind here, palpation is a skill. So this research was done with the instructors. We have a meeting every month, and we spend a lot of time and energy being very tuned in to what we can feel. So here's what we did. We palpated on this patient's right side where we found the restriction, and 2 of the providers agreed that this number 1 adhesion here was the primary, while the 3rd provider determined that number 2 was the primary. So we did all agree that both areas were present at the end. But what we did do was discuss, hey, wait a minute, why did you feel that the two providers that felt it nestled up in here next to the piriformis, but on the supraumbillaris adjacent to the sciatic nerve? And what happened here is that this third provider just didn't palpate far enough up the nerve. So when we're in this setting, there's a lot going on, and just like in practice, there are days when you can just not be as thorough as you would like. So the nice thing is 2 out of 3 of us agreed. When we discussed it and repalpated, all of us agreed. And we also all agreed that number 1 and number 2 were present, and they would both need treatment. So this patient's sciatic nerve and external rotators had these 2 adhesions present. The other thing we do is grade the adhesion. So we do 0 being none, 1 mild, 2 moderate, and 3 severe. All of the providers graded this as a moderate, and that was a blinded grading. We found there was enough in here to say, hey, you're in the middle third of patients we see. It's not terrible, and it's not a little. It's just in the middle. So we all felt these adhesions. We all agreed on their severity, and we all had similar measurements. Next up is treatment. So we do manual adhesion release, and this is a procedure that's unique to integrative diagnosis. The first 2 providers each made a single pass on the adhesion, and then we remeasured straight leg raise blinded as we did the initial measurement. So here you can see we're just measuring the right side. So each of those first 2 providers made a single pass. But keep in mind, this isn't guesswork, and we're not treating structures. We are treating the adhesion that we palpated, and it's very specific technique. There's nothing else this specific in manual medicine. Post, we again blinded. This time we get 83, 82, and 80. These results are nothing shy of remarkable. That's 81. I actually had to go to decimals because they became relevant with how close these numbers are. So it's 81.5 is the weighted average, and it's plus or minus a degree and a half. You really can't get people to look at an inclinometer and agree within a degree and a half of just where it's sitting. So this is remarkable. Number 1, this shows, again, additional accuracy. Number 2 is the change. This went from 67 to 81.5 degrees. That's 14.5 degrees of an increase in straight leg raise with 2 expert passes. So we're measuring the thing we want to measure reliably, and we're improving it via treating adhesion. So over here on the side of this slide, this isn't arguable. Adhesion exists. It limits straight leg raise. Experts can palpate it, feel it, identify it, grade it, and reduce it with expert treatment. That's what this shows. So you might be thinking, okay, but I could stretch them out, or I could adjust their low back, and I could get changes. Maybe not 14 or 15 degrees worth, but I can get changes in straight leg raise. So the next step, well, sorry, I got ahead of myself here on the slides. So that was the first 2 providers that did this. The third provider then continued and made another pass of manual adhesion release on the remaining adhesion, because we palpated it again and found there's still adhesion present, although it's reduced. The sciatic nerve mobility is increased. The definition of the space had improved, but we made one last pass at it. After the last provider treated this, we took 2 measurements. We got a 91 degrees and an 88 degrees. Now, why didn't we have 3 people measure this? At this point, we were convinced that the straight leg raise is reproducible, and this was an informal project. When we started it, one of us just needed this treatment. So we were actually just getting a little bit distracted at this point. But what you'll see here again is that these two numbers were close enough. So we had run that experiment. We were happy with the results. The benefit of hindsight, knowing that we were going to be sharing this, we certainly would have had that third person do this. So here's what we've got. That's a weighted average of 89.5, and it's the same range, plus or minus a degree and a half. So now we've gone from 67 degrees to 89.5 degrees, right? And this should say with 3 passes, because this was the third provider. So 3 different people, each doing 1 pass, added 22.5 degrees to this straight leg raise. And adhesion was now graded as 0, being none. This is a demonstration of absolute expert palpation in treatment skill. So now we get to the part where people can be like, well, I do that with stretching, I do that with adjustments, I do that with ice or KT tape. And here's, again, one of the fundamental principles of IB is defining treatment. Treatment must reduce a dysfunction, meaning it restores normal load, and it must be safe, efficacious, and durable. So what we're looking at right now is the question, is it durable? Because yes, you could have somebody stretch, you could have them go into a sauna, you could rub on them, and you will get changes in ranges. But what they won't be is durable, especially when it's a nerve entrapment, as in this case. If you stretch this, you do not reduce the adhesion, you just temporarily increase some pliability, either in the tissues or the adhesion, and they get a couple more degrees. So you don't get 20 degrees, but the big thing here is it durable? So 1 month follow-up with no additional treatment. Straight leg raise on the right was now measured independently and blinded at 83, 87, 86. And just for kickers, we had an additional person measure this 5 days beforehand in a separate setting and came in at 85 degrees. So that's 4 separate blinded measurements. Now we've got a weighted average of 85 plus or minus only 2 degrees. This clearly shows that the procedure of straight leg raise measurement is indeed, these are just more and more robust data. Now we have a sustained increase of 18 degrees. So this patient went from 67 degrees to start to 89.5 after 3 passes to a month later being at 85 degrees. What this tells me is that adhesion was responsible for the limited straight leg raise, and reduction of that adhesion increased and improved the straight leg raise because now the nerve is able to floss properly. And without a reason for it to come back, it stays gone. That is safe, efficacious, and durable treatment. Furthermore, we also asked the patient, how are you feeling? And the patient reported a 90% decrease in hip, posterior hip, and low back symptoms. Wow, this is just an example of if this is the problem you have, this is the treatment you need. So if you're not measuring straight leg raise, you have to start. And if you don't know the list of things that block straight leg raise, you have to learn it. And then you have to have the skills to address those pathologies that limit straight leg raise. So at the very least, measure it. Here's what we've got. We did the math on all, the left, the right side, and then post-treatment, and then 1 month follow-up. And basically what we're looking at here is the total variation in straight leg raise is about plus or minus 2.5 degrees. That's a phenomenal reliability for, again, a physical test where you measure at the start, you measure at the end, and the instruction is to go to moderate stretch. We've got a whole bunch of other instructions there, but that's a remarkably precise and accurate test. So what's the story here? This is one example of a small piece of what integrative diagnosis does. So where are the opportunities for this type of healthcare? What's the payoff for the provider and the patient? And we think it's pretty straightforward. You build your skills. This is an example of being able to test something that's important, to palpate tissues, and to, in this case, reduce adhesion. Incredibly valuable skills. Why? Because skills provide insane value. If you can change someone's straight leg raise in one visit with 3 passes, and it be 20 degrees better, and at a month follow-up, still be remarkably improved, that is insane value. 90% decrease in symptom and an 18-degree increase in the range. This allows you, with these skills and this value proposition, you call your own shots. We've got providers that are absolutely dropping all insurance. As you know, insurance is falling apart. We're getting 20 to 50% pay cuts routinely. Not fair. Clinical excellence should be rewarded, not punished. So the good ID providers are going cash. We're even going case fee, where we do an upfront price for the whole case. The fee for service, nickel and diming, no good. So when you've got skills and you've got value, you call your own shots, meaning you can drop insurance, charge what you want, also do what you want during a visit. You're not beholden to an insurance company to prove you did something worthwhile. And you take back your pricing power. Who's to tell you that your treatment's worth $25 or $50 or $100 or $3,000 per case? That's between you and your patient, not third parties that are interested in cutting only costs. So this brings us to huge competitive advantage. When you can do things based on your skills and values that other people can't, people will seek you out. This is what ID does for you. There is a caveat here. This isn't free. We have all spent decades getting this good. So if you can take a couple of ID courses and add 5 degrees to this straight leg raise, that's still an amazing amount. If that would take you 4 or 6 visits instead of 1, that is still amazing. What we're showing you here is the top of the mountain in possibility. But you have to put in the hard work, the time, make the investment, and you got to stick out what we call the valley of doubt. When you go from current practice standards to standards of excellence, it's tough. I'm not here to tell you otherwise. There's a lot to learn, there's a lot to do, and there are no shortcuts. But I hope you can watch this video and re-watch this video and see that there's something unique and amazing happening here, and that you want to be part of this process. Right. Thank you for your time and attention. And we go to integrativediagnosis.com and sign up for the online program. All of our educational material begins with the online subscription. Thank you.